session today is co-presented by the Ottawa Hospital Research Institute, the Ottawa Method Centre and the Centre for Implementation Research, along with the Accelerating Clinical Trials Consortium. You may have seen this recently announced. This is a major investment by the Government of Canada into developing the ecosystem for clinical trials. And I'm going to hand you over to my colleague, Friedman, who's going to say a few words about ACT and some of those initiatives.
Hey everyone, good morning. Thank you, Stuart, for the introduction. My name is Eva. I'm a research coordinator at the ACT Consortium. So just briefly, you can see on the right on this presentation slide, a Be the Cure campaign. So I'm just going to talk quickly about it, and then I'll talk about what is ACT. So Be the Cure campaign is ACT's public awareness initiative, highlighting the benefits of health research. So the goals of this campaign are to raise public awareness about the value of randomized controlled trials and also encourage trial participation. So what we did, we created a database of ACT trials, and we're trying to encourage the public to access the database and look into any potential studies that they might be interested to participate in. And I would highly recommend for everyone here to check it out. And there is, the website is on the slide. And let me just now talk about ACT as well. So ACT stands for, like Stuart mentioned, Accelerating Clinical Trials. This consortium was established to accelerate, optimize, and facilitate the conduct, implementation, and results of translation from high quality, high impact randomized controlled trials to improved health in Canada. We bring together hundreds of researchers from 28 research networks, 11 trial units, patient partners, the biotechnology industry, government, and experts in research ethics, contracts, insurance, regulatory processes, training, communications, and knowledge mobilization. So we have a lot of collaborators, and they are scattered across the country, representing every region of Canada. In the next slide, you can see the many objectives that we have. But I want to bring your attention to the ones in red, which are focusing on enhancing equity, diversity, and inclusion in clinical trials. And in the next slide, what you can see is our governance model. So we have different committees and working groups that are focused on addressing the consortium's objectives. We have a committee dedicated to engagement with patient partners. We have an Indigenous committee focused on prioritizing their unique health concerns. And we also have a committee dedicated to fostering a robust equity, diversity, and inclusion approach to clinical trials. In the next slide, I gathered the objectives of our EDI committee. What they do, they focus around increasing representation, identifying barriers and facilitators, and applying knowledge acquired towards developing metrics and kits to guide the researchers in implementing ADI into study design, as well as the recruitment process. And also the committee is trying to avoid resource duplication. So they scan for existing resources, and then they use different methods like, for example, focus groups to identify any gaps in the current landscape. And that's all from me and from ACT. Thank you very much.
Thank you, Eva. So it gives me great pleasure to now introduce our speaker, Dr. Victoria Shepard, who's a senior research fellow and registered nurse at the Centre for Trials Research at Cardiff University in Wales in the UK, where she leads a programme of interdisciplinary research exploring inclusivity in trials with a particular focus on populations where consent can be challenging. She co-leads the inclusivity theme of the TMRP Trials Conduct Working Group and led the development of the CIHR Include Impaired Capacity to Consent framework. The paper reporting the development and implementation has just been published. I'll mention that briefly in a moment. But she also leads a number of methodological studies embedded in clinical trials to ensure that they're more inclusive of underserved groups and help to develop the evidence-based strategies to support the inclusion of those groups in future trials. So she works within the Centre for Trials Research and leads the Inclusivity in Trials Studies group, which supports the Centre and its collaborators to design and conduct more inclusive trials. You'll see the links here on the slide. And the slides will be made available afterwards as long with the recording, so don't feel you have to try and copy them down now. And the talk couldn't be more perfectly timed because this was published just over a week ago, and we'll touch on and we'll talk about this framework now. So it gives me great pleasure to hand over to Dr. Shepard and take it away.
Thank you so much for your welcome, Stuart. It's lovely to have everyone here and joining online. So today I'm going to kind of revisit why inclusivity in trials is important, in case that's a kind of message that's newer to some people. Talk a little bit about some of the initiatives going on in the UK, particularly coming out of the National Institute for Health and Care Research, the NIHR, and their Include initiative. And then talk a little bit about the work that I lead in this area, focusing on one particular underserved group, and that is, as Stuart mentioned, groups that might not be able to provide their own consent, and talk about some of the kind of tools and associated work that we've been doing to support their inclusion. So inclusivity in trials, really important. We've already heard a lot about how ACT are very committed to this agenda as well. But in case it needs saying again, research, of course, is essential to improving the health and well-being of all in society. What we do know is that not everyone has equal access to take part in trials. And of course, without a diverse range of research participants, it's really hard to see how the trials that we run, the findings that we spend a long time working on, will actually translate into real world meaningful benefits for the groups that should be receiving the treatment or other intervention. And of course, trials don't sit separate to the rest of that kind of health and care ecosystem. And so a lot of the challenges around the inclusivity in trials map onto the same kind of inequalities we see more broadly for people's health and well-being, but also when we think about access to healthcare delivery and services. And as part of that kind of widening participation in healthcare services and reducing health inequalities, addressing research inequalities through more inclusive research is a really key priority, both for funders, certainly in the UK and beyond, and for other groups as well. And again, that's part of their commitment as well. When it comes to which groups we might think perhaps are underserved by research, we often think about them in terms of the kind of protected characteristics that you might expect, sex, gender, so on. But actually, it's much more complex than that. And it's intersectional, so of course, people may have more than one identity or characteristic that leads them being underserved by research, but also context specific. So it might depend on the kind of health condition, on the population, on geography as well. But thinking about this kind of increasing focus on how we can ensure that groups who are underserved by research are better included, the NIHR in the UK have kind of given a signal about what some of the characteristics are about groups and why they might be underserved in research. So that's groups that have a low inclusion in research that might be expected from population estimates, where they have healthcare needs that are higher perhaps than others, and that's not matched by the volume of research or the quality of research designed for that group. And importantly, where there might be important differences in how they might respond to or engage with an intervention. So we cannot assume that what we find from one population is transferable to this population. And I've mentioned how it might include demographic characteristics, but also beyond that. So think about the kind of social, economic factors, health status, and other characteristics. And of course, why it's important is that we include these groups in research. I've mentioned already about that generalizability argument, so they might respond to the intervention differently. Benefit and risk profile might be different for some groups. It might be effective, but it might not be as safe for these groups. But also that kind of rights-based argument as well, that people should have the opportunity to contribute to and benefit from research, and that should be equitable across all in society. And this kind of justice idea as well. So the term epistemic injustice, so it's who we think has knowledge that should contribute to the world and who we should be listening to. And that's that kind of having a voice idea, that actually if these groups go unheard, we don't hear what their needs are, we can't address their needs. And the term I often think in terms of is that actually if we exclude these groups from research, we end up with evidence-biased care. We have more evidence for some groups that contributes to this widening of the health and care inequalities that many of these groups experience. We might think about some particular groups, and in previous presentations I've talked about COVID, but I know everyone is really fed up of hearing about COVID, but we might think about that as a really good example about how some groups that bore a particular burden of COVID and poor outcomes were not included in research. People with a learning disability might well be one of those groups. But thinking about from a kind of non-COVID perspective, certainly in the UK, and this is an international experience as well, people with a learning disability die on average 20 to 30 years earlier than people without a learning disability, often due to very conditions that are really relatively easy to address. And you can see there some examples about the level of impairment might then link again to worsening outcomes for some of these populations. And why is that? Well, what we also know is that about 90% of clinical trials are designed in such a way as to automatically exclude people with disability from taking part. And that's general research, so not focusing on the needs, particularly of people with disability, but we might think about diabetes, for example, cardiovascular trials. And as a group, we might think about people from ethnic minority groups as well, and you can see there screenshot from Cancer Research UK. We talk very much about how there are ethnically based disparities in cancer, again, poorer outcomes, and that might be due to access to screening, for example, reporting symptoms, but also the treatment that's provided and having poorer outcomes from that treatment as well. And again, you can see that the report at the bottom talks about how there's lower inclusion rates of people from minority ethnic background in cancer trials. Just to highlight, it's not necessarily thinking about minority populations as a whole. So women, of course, make up around 50% of the population. But you can see on the left-hand side of the screen there a report from late last year that talked about the inequalities in women's health when it comes to cardiovascular conditions in the UK. That was talking about a meta-analysis done looking at the most common heart conditions. And you can see on the right there that I've picked up on some of the idea that it's not just access to trials, but it's how we think about symptoms, how these groups, for example, women might delay seeking help, there might be less recognition because of the different symptoms they might present, that then they might be less likely to receive what we know are evidence-based treatments, including transportation to hospital with blue lights and sirens blazing, and also picks up on the idea that medical textbooks, of course, have been designed with men's health in mind, not so much thinking about women, and then that kind of assumptions made as well. So we can see it goes beyond trials and kind of across many kind of sectors of people's health and well-being. And I mentioned at the beginning, increasing focus on addressing medical inclusivity in the UK and again around the world. So our main funder, the CIHR, talks very much about in their best research for best health, their future-looking report, how research needs to follow need. And when we apply for funding, you can see that the kind of map on the screen there. Part of what we have to explain is how, for example, the trial recruitment sites we have will match where the burden of that condition is really geographically spread compared to where our main research centres are, and you can see which is which on the screen there. This also follows research governance, so when we think about Research Ethics Committee, which in the UK are coordinated by the Health Research Authority and a little bit differently in Wales and Scotland, and again very committed to the idea that we need to increase the diversity of people taking part in our research in order to meet the needs of that wider population. And then also kind of legislative drivers coming in as well. So our new clinical trials regulations will also include that as part of a regulatory perspective, we will need to justify why our trial population does or doesn't look like the clinical population. So all these kind of driving change in this kind of sector. And then taking a moment just to think about what some of the barriers are, because they are on the surface quite simple, but actually much more complex than that. And I quite like this cartoon as a really nice kind of description that highlights how some of it is kind of intentional. So when we set the eligibility criteria for our trials, how actually that limits who can and can't take part. And historically, we've moved away a little bit from the kind of strict upper limit of age and the challenging those kind of eligibility criteria a lot more. Increasingly, we might think about the ones on the right, which are kind of unintentional criteria as well. So if we exclude anyone who's got a comorbid condition, for example, anyone with prior malignancy, even if that's not necessarily related to the clinical trial we're running now, we again are narrowing who actually has the ability to take part. And not just those kind of design conditions, but also the kind of more practical elements as well. And that's the kind of stairs you can see people facing, not being able to climb. So that might be, again, geography, so where we run our clinical trials. It might be that we're running them increasingly online, so remote participation, not accessible to people who are digitally excluded for various reasons, but also that you might need someone to accompany you. It might be within working hours. It can be multiple reasons. The literature talks a lot about what some of those barriers might be. I've put a little star there because a lot of this is drawn from the literature around including people from ethnic minority backgrounds in clinical trials, because that's been a large focus. So some of them may or may not be applicable to other populations. Language and communication. So we might see an exclusion criteria that someone needs to speak language in order to take part, that kind of literacy level, thinking about information sheets and how complex they might be. I've mentioned about access physically to trials or not, but also there's kind of bigger issues as well. When we think about trust, when we think about knowledge about clinical trials, we think about attitudes and beliefs and how that might be different for some groups compared to others. And then also the kind of other barriers at the bottom, so lack of recruiting staff, or those that have particular skills, cultural awareness, for example, or where we might actually have very small populations. Challenge of running trials that I'm sure a lot of people really recognise, where actually you're only talking about very small populations. So I'll move on then, rather than focus too much on the barriers, to think about actually what might be some of the ways that we can support inclusion, and particularly about the NIHR's Include initiative. So this was commissioned a few years ago in the UK by the NIHR, and this was a programme and initiative looking at how we can improve the inclusion of underserved groups in research more broadly, but obviously thinking very much about clinical trials. And that led to them producing this kind of roadmap that you can see there, the idea being that it's kind of intervention points as we design and conduct a trial, where there might be kind of opportunities to think about actually how we can make sure that this trial is more inclusive of particular groups. And that ranges from research priority setting, so thinking about whose priorities those are, to funding decisions, then we actually design the study itself, and then right through to that kind of impact, dissemination, engagement, again, who we reach when we are sharing the findings from our trials. And that's been published in a paper that's available. You can see the bottom there, where all the NIHR Include resources can be found. They've also developed training for research delivery staff, thinking around reaching a diverse range of participants, and other guidance as well. They have a resource tracker, so again, you can access all the different kinds of resources and links to other sources, all available on that website. And then moving on to think specifically now about designing trials. So a lot of this work can be found on the Trial Forward website, again, that you can see at the bottom. And that brings together a whole range of resources led by Professor Sean Drake from Aberdeen. And it's the idea being that incremental gains, I guess, drawn from kind of sports and other kind of arenas, that actually if we regularly make what might be quite small changes, what might be more large and more meaningful changes, together we can actually change trial design so it can be more inclusive. And that led to questions to guide research teams that came out of the ACT-AEC Include work around designing research. So these are questions that at the very earliest stages when designing a trial we can ask ourselves. So this all thinking about the kind of population that research is actually looking to serve, thinking about our eligibility criteria, how that will enable you or not to match the population, and then thinking actually, can you justify any difference between that? And that will be really key to that line. Thinking about how your recruitment and retention methods might engage or not with particular underserved groups. And again, that could be from a range of perspectives. And then also thinking about what evidence you have that your intervention is feasible and accessible to populations. So we can't only think about this at the kind of phase 3 later stage trial. We need to be thinking about that as we're developing interventions, as we're developing outcome measures. Similarly, are those validated? Are those relevant to the population your research seeks to serve? And that might be the idea that as clinicians, the researchers, we think certain outcomes are very important. But actually, is that really the case for some of these groups? And the last stages of the Include initiative was to produce some more kind of concrete tools to help researchers to to actually design more inclusive research. And these are the include frameworks you can see at the bottom. So the first was the include ethnicity framework, a structure for all researchers to work through. Think actually, is their trial designed in a way that will be able to be inclusive of people from minority ethnic backgrounds? And that was produced during the kind of COVID trial era, particularly, but that remains very relevant now. And that same kind of approach is adopted to think about groups who might be socioeconomically disadvantaged, so groups that might not have the resources to travel to a clinical trial centre, might be part of the district included population, who might not be able to take time off work to attend population appointments, for example. And then that same approach I've taken to develop the impaired capacity and consent framework that Stuart very kindly mentioned, and I'll come on to talk a bit more in just a moment. And also some more guidance, so a little bit different from the include framework, but guidance around how we can include all the people in research has also been published. And again, all of those can be found on that Trial Forge website. And then alongside that, there's a whole kind of plethora of kind of different strategies and projects and work gone on, again, to support inclusion. So Trial Forge Guidance 3 talks around how we can recruit and retain people from ethnic minority groups, a very practically focused guidance with links to resources. And part of what comes up a lot in this is actually how we will know who we've included in the population in trials, and without being able to record some data on who we're perhaps approaching, recruiting, keeping in our trials, won't actually be able to monitor and report who has or hasn't been included in the trial. So that was some work done on the right-hand side around thinking about collecting and reporting ethnicity data. Lots of questions come up in our trials unit, and probably similarly, about what kind of categories we present to people. We ask them to identify when we use medical records, for example, to identify people's ethnicity in a way that they might not have reported it, might not be the way that they would identify for themselves. Again, those resources can be found online. And then what I'll do is move on to think about the particular work that I lead around a particular underserved groups, which are adults with impaired capacity and consent. And on the kind of surface, we might not think of this as a kind of inclusivity question. But what we do know is that actually this group are largely excluded from trials, and that's even the case where there are quite high levels of cognitive impairment in the clinical population. I've put some examples there. So the hip fractures is a really classic example where 1 in 3 patients also have cognitive impairment. That might be dementia, that might be delirium, but actually 8 out of 10 of hip fracture trials either exclude or ignore this population. They don't really address whether they should or shouldn't. We see that in studies in older people, even though, of course, cognitive impairment likely to rise as people age. And more broadly, communication-based exclusion, around trials excluding people with a learning disability. And again, that might be due to the readability age of our information sheets. It might be that you have to find it on a website. It might be that the people approaching you to explain about a trial take a view about whether you would or wouldn't be interested in taking part, be able to understand the information, that kind of gatekeeping perspective that we see quite commonly. And this isn't only limited to populations that have cognitive impairment, perhaps through a kind of long-standing or degenerative condition. It also occurs in more urgent and emergency trials as well. My background's in critical care nursing, so this is the kind of population that I've done a lot of work with in the past. And we see that the kind of consent model used actually limits who can take part in the trial. And again, this was a classic example from quite a few years ago. Actually, the way that they had designed the consent model meant that the population they actually included in their trial was unrepresentative. They were far less sick than the actual clinical population, and the trial was halted for a lack of efficacy, whereas it might actually have been effective had they recruited the right kind of population. And you can see the quote down the right-hand side that talks about how it's important not to exclude people with that capacity from taking part in research, in exactly the same way that we wouldn't think it right to exclude them from accessing services and medical treatment. And what are some of the barriers? Well, really complex, I think, is the kind of short answer here. But you can see some of the work I did there to kind of tease out what some of those might be. So some of them are kind of more systemic. So the complexity of the legal frameworks, and if you've ever engaged in that, You'll understand quite why that is quite complex to navigate. Ethical review processes come up a lot, and the challenges of getting a trial through ethics review panel where you're seeking to include people who lack capacity to consent. And I've mentioned already that paternalistic protection, but quite rightly, ethics committees, clinicians, family members are also seeking to protect the rights and the well-being of people that they care for or are seen to represent. But that might go to the extent of preventing them from accessing treatment and having improved medical care in the future. And then there are more kind of structural issues as well. So resources required. So it can take longer, it can take more resource, it can take more highly trained staff to actually approach and recruit people who lack capacity, assessing capacity, supporting people's communication and decision making, for example, takes longer. And then where you might need to then involve an alternative decision maker. So identify a family member, explain about the trial, seek their agreement for the person. Again, you've got that kind of greater resource need compared to other trials. And research infrastructure as well. So it's primarily been designed for people that can give their own consent. We're all about efficiency these days and how we can do that in a way that actually informs people, but then we can recruit the numbers that we need to in our trials. And all that has not necessarily been designed to take account of people's additional communication and capacity needs. And the lack of support. So I hear it over and over again that actually researchers don't really know necessarily how that they can design a trial to be inclusive of this population and don't know where to turn for support. And then there are kind of methodological issues as well. Again, restrictive eligibility criteria, think how often you see us be able to provide written informed consent, for example, but also those kind of interventions, particularly when there might be a complex intervention, how appropriate is it for this population? I've already mentioned about outcome measures. Where there are alternate consent pathways, so where you might need to use deferred consent, for example, without prior consent in emergency, or when you might need to involve alternate decision makers. And all of that can make this quite complex. One of the studies I did a couple of years ago was interviewing researchers and others to get a sense of what they thought the kind of barriers and facilities might be. You can see the kind of three themes across the top there. So again, that complexity of trials, the need for appropriate support and resources, but also the need for greater knowledge and expertise. So they know where to go to find statistical expertise, for example, but perhaps not methodological expertise in this population. And the challenges kind of were throughout the kind of research cycle, as you can see there. So when thinking about designing a trial, when going through ethical, when recruiting participants, assessing capacity, seeking to retain them in the trial, whether they might lose capacity or regain capacity after that point, and how you might revisit that. And you can see the quotes there on the far left-hand side. And this was a researcher that was involved in care home research. So we might know that upwards of 70% of people sitting in the UK living in a care home will lack capacity to consent. But they never involved that population in any of their care home studies because they spoke about how actually just even thinking about that complexity was insurmountable. Like this black box of horrendousness that they dare not go near. They worry about the ethics police coming for them. So you can see how that kind of lack of knowledge and concern plays out then in the we reported that and then also created a kind of series of recommendations for research funders and governments and researchers beyond. And part of what they told us was that actually that kind of methodological gap that people had, that they would appreciate more support. So adapting the include ethnicity framework, we then developed the include impaired capacity consent work that has just been published. We produced this with a range of researchers across different populations because, of course, the challenges and the barriers and facilitators might be quite different if you're running a trial with people with dementia, for example, compared to a critical care trial. So we developed this in conjunction with researchers drawn from across those different kind of populations, types of trials, and importantly with people living with a range of capacity affected conditions and their families as well. We produced it over 5 stages from the kind of core concept and whether that kind of proof of concept worked. We adapted the ethnicity framework. We asked trial teams to trial it for us, to pilot it and see how they found it. We held focus groups with public involvement contributors to then review what we were including in our framework, see if there were areas that we missing. We then finalised it, and then importantly, these kind of interventions, support tools, you could just put on a shelf on the website, and no one will actually pick it up and use it in practice. So we developed a whole kind of implementation program using behavioural science, so organisation process theory, to develop a theoretically informed implementation toolkit to actually help researchers to use this. And because we know that they also will need some additional support, we have a whole website of collated resources, so examples of information sheet that are more accessible, and various other kind of tools that researchers can use to help them. We launched this as a webinar towards the end of 2022, and that was really well attended. And we also learned from the kind of frequently asked questions that came up in that framework webinar and beyond, to develop a kind of FAQ to go alongside that as well. And that's very much a kind of living document. So as people take this up in practice, we'll be able to revise and refine tools that go alongside it. So in terms of the contents, and you can see there some of the front cover and the infographics that we produced to share knowledge of this resource. And using the same structure as the ethnicity framework, we have 4 key questions for researchers. Each one then has worksheets for researchers to kind of work through to actually tease out in a bit more detail. And the final section is where they can actually summarise the actions and resources. So that might be, for example, that including some of those additional resources in the funding application to demonstrate to funders why you need those additional resources, why this trial might be more expensive trial without this population, because you have appropriately costed in the resources, having planned ahead to include these populations. And again, funders by and large are very well aware of that need to include a range of participants. You can see that the question 1 there thinks about how you will know who your trial should apply to. That is a really tricky question. That takes a lot of thinking and a lot of work through. The framework can't help you directly to answer that question, but it's more about triggering discussion amongst the research team. Then thinking about whether they're likely to respond to the intervention in a different way, and it might be different for perhaps different types of disability or not. Will the intervention make it harder for them to respond? Is there a way that you can adapt to that? Thinking about how it's delivered, when it's delivered, where it's delivered, which of course will depend on the nature of that intervention. And then where the core part of the work goes is that question for thinking about the trial design and whether it might make it harder for them to take part or not. Again, think about eligibility, think about the routes to recruitment, who's going to be doing the recruitment, the consent model, how you'll be collecting data collection, what tools you'll be using. Again, is it online? Is it paper-based? Can there be an easy read version of that? And then how you'll be analysing and reporting this. So what we do know is that as trialists, we're not very good at reporting in any great depth who's taking part in our trials, which means we can't really look and see whether the trial population reflects the clinical population or not. And then dissemination. So all the routes that we've gone down to make sure that we recruit the various participants, we need to mirror when we think about dissemination. So are we similarly making it an accessible formats so that it reaches the sort of people who took part or would take part in the future? And you can see on the right hand side there some of those tools that we've developed alongside. That's the website at the top, a summary of the legal frameworks. As in Canada and the UK, we have a kind of patchwork of legal frameworks that cover this, so it varies depending on where you are based and the type of trial, whether it's a clinical trial or not. We've developed the whole kind of library of completed frameworks because researchers told us that actually even knowing where to start, so they could take a look at completed frameworks and use that as a starting point for their own trial. And then at the bottom, you can see an easy read guide to using the framework, and this was really key. So we worked with a company called Inclusive, graphic design specialists in accessible information, and they co-produced this with their group. And this means that actually public involvement, of course, is a key part to ensuring inclusivity in trials and trial design more broadly, but supporting people that might have issues around communication and capacity to contribute to those public involvement discussions is really key. So this talks about what clinical trials are, and then goes on to talk about the questions that will come up in the framework to support discussions with public involvement contributors. Some key recommendations for using the Include framework, and they might be equally relevant to when thinking about some of the other include frameworks. But this is very much a collaborative process. This isn't one person's responsibility. It's not the trial manager or whoever might be responsible for leading some of this practical component. It's very much across the whole trial team. I mentioned already that public involvement that is inclusive of these groups is, of course, essential throughout. We think the framework is useful for pretty much all populations who experience impaired capacity and for all types of studies, although it's been designed with trials in mind. It's probably useful if it's not a trial that you're considering. But all of this is key to use at the earliest opportunity. And we often talk about the kind of metaphor of a blueberry muffin. So if you want a blueberry muffin, there's no good making a muffin and trying to poke blueberries into it down the line. You need them in there as essential ingredients on the outset. And it's exactly the same with inclusivity in trials. Because the legal framework will dictate a lot of what you are and aren't able to do, you need to consider that at the earliest point, not getting again too far down. But there are those tools that can help people unpick some of that. And importantly, setting aside time to address inclusivity and include any associated cost in the funding application, which might be more research based time, for example. It might be using some of the tools that can support decision-making and communication. We also know that actually there's not a lot of training on how to design and conduct trials involving people with impaired capacity consent. So that's the work that we're now leading this year. So stakeholder informed. So we're asking people to tell us what particular issues they've come up with, what particular challenges, examples where things have gone well, so they can share best practice as well. And within that, designing an e-learning resource to be available later this year as well. And then just in the last couple of minutes, because of course, tools to design trials are all well and good. That's not the only issue that we don't address. What we also know is actually when we ask, for example, family members to make a decision on their behalf about whether it should be included in a trial or not, that's a really hard decision for some people to make. And family members often experience quite an emotional decision burden. That means that they're less likely to agree to participation than patients do themselves, but they also carry that kind of burden, are more likely to then experience psychological stress. Drawing on decision aids, which are tools to help people make a more informed decision about their care and treatment, we've developed a decision aid to support family members to make decisions on behalf of someone about research. It's generic, so it goes alongside the information for that particular trial, but again, it helps the proxy decision maker go through a kind of structured way of thinking about what the person they're representing would have wanted to do about this. We're evaluating whether it's effective or not in a SWOT, so a study within a trial. So these embedded methodological studies where you can actually test a recruitment or retention intervention. People are randomized to receive it or standard information alone in 5 different host trials to get an idea about whether it might help some populations compared to others. And we've developed a primary outcome measure, the Concord scale, to measure the quality of the decisions, basically whether it's informed, whether it represents the person's wishes or not. And what we also know is that people don't talk about their wishes about research in the way that people might talk about organisation or perhaps other things that they think is important for them should they lose capacity. So part of what I'm looking currently is whether the idea of advanced research planning, so this idea of supporting people to discuss, talk about, perhaps document what their wishes would be about research at some point in the future should they lose capacity, and to say who they would like to act as decision makers. So this is an idea that's been knocking around for about 30 years, first talked about in Canada, so to some degree the kind of birthplace of some of this, and the idea of advanced research directives where people can record their preferences about research. So I'm doing some work leading that in the UK, thinking about whether it might be acceptable or feasible in the UK. It's one of those ideas that people think is a really great idea, and then when you actually explore in practice, it is more complex because it might be a legal process, it might be an informal process, how and where it's recorded, who might be interested, motivated. So that's the work I'm leading at the moment, and that will lead to developing an intervention in this space in the future, informed by people I'm talking to here in Canada and then Australia. So finally, one of the other ideas is that other methodological studies can be embedded in clinical trials. So I've mentioned SWOTs already, where you might test a recruitment or retention intervention. But the NIHR are also funding SWOTs, so a study within the project, So this might not be testing or exploring one particular intervention, but more about thinking about what we can learn methodologically to make a trial more inclusive, particularly of people with multiple long-term conditions. So as we're aging and living longer, more likely to be excluded from trials, but that's increasingly going to be the clinical population. So they fund a swap that you embed in a clinical trial. I'm leading two back in Cardiff. So one is a radiotherapy trial. So again, cancer, more likely as you get older, but then more likely to exclude frailer older people. And then a complex intervention focusing on self-management support for people with osteoarthritis, again, a condition of aging. So we're embedding that throughout the trials, learning more about how we can make it inclusive, and that might be the recruitment routes, it might be other aspects, and then that will inform both those trials, and we can share that methodological learning for future trials as well. So I'll conclude. So trials we know do not currently reflect the populations that actually we see in clinical practice, resulting in this evidence bias and exacerbating health inequalities that many groups have experienced. We urgently need to change the way we design and conduct health research. That there are some common underpinning principles, but also context-specific things that we need to do. Work from including the include frameworks can help us design research that's more inclusive of underserved populations, and another work like the consult program I lead, thinking about particular interventions that also support inclusion. Trial methodology research, where it's possible, where it's funded, where we have the time and space to do that, might also help us to deliver evidence-based strategies to improve inclusion in the future. I'll leave it there. Thank you.
I don't know if anyone in the room has questions. I'm not seeing anything at the minute online, so happy to go to the.
Thanks very much. My name is Andrew, one of the new investigators, clinician scientist. So my question is related to capacity building. So you mentioned that, sort of coming up with a framework, of course, using behavioral science methodologies to make it accessible through different worksheets. And I know you mentioned a bit about e-learning in terms of making that accessible to researchers. Are there sort of plans for seminars, sort of a more integrated in-person sort of training program for junior investigators, so that it's sort of embedded from day one in terms of their thinking about inclusion in clinical trials?
Yeah, thank you very much. And you're absolutely right that it's partly a mindset. So it's about being alert to the idea of inclusivity. You can do that at the kind of earliest stage, and then also having the kind of knowledge, skills, support to enable us to do that. And we do that in a couple of different ways. So the kind of webinars that we hold, so through our clinical trials unit and beyond, we do a lot of work around inclusivity, and then also focusing on some of these kind of tools as part of that kind of reaching. And then also more focused webinars as well. So we did that kind of launch when we launched this particular include framework. We learned a lot from that. People would appreciate that kind of interactive component as well. So as we develop our training, we'll partly be supporting that through more focused webinars. Again, when we have a bit more time and space to talk through what some of the issues are, knowing that they might be context specific, for example. So we've done work with people working in dementia research, for example, but also anesthetics and other kind of clinical populations where capacity and consent is not their primary focus, like it might be in dementia, but is a key part of the kind of clinical population. So you're right, it needs to be a kind of combination.
Got a question online from Corey Goldstein, who says, thanks for the talk. I'm curious about whether there are ongoing or planned evaluations of the uptake of the various frameworks and toolkits that have been developed to help researchers recruit more underserved populations.
Yes, and that's a really good question. And evaluating uptake of these kind of tools is quite tricky. So we can measure it in terms of accessing. So access from the paper, we'll know how many people cited, for example, but that might not be the same about uptake, and it might not be the same about actually using them in the way that we intended them to, whether people will adapt and change like they will do for any intervention. So that is part of future work, to has been some evaluation of the ethnicity framework that's given us a really good clue about how these things do sometimes get used. What we also know is that I see it when I review funding applications, people talk a lot about how they've used it. We will use it, we have used it, we've done a good job, honestly. And then when actually you can see what they then have designed their trial, you get a really good idea that actually they probably either haven't used it in the way it's intended to be used, or it's not been effective. So that very much will be the future work to do. And I think that kind of behavioural part is part of it. And a lot of this is thinking about the kind of barriers that trials might focus on in terms of recruiting quickly, recruiting kind of see that move towards efficient trials. How actually trials that then aren't recruiting to some target get shut down, even though it might be because they've taken more time, because they're trying to be more inclusive. So they might not have the recruitment numbers, but actually they've done a really good job of reaching underserved populations. So the bigger questions around how funders, others, view that agenda alongside you have to recruit X number by X number of months, or you won't progress. And that is a bigger question, bigger challenge.
Yeah, thank you. It has been a phenomenal presentation. A lot of things to jump on, and I'm sorry, I'm afraid I'm going to make a quite complicated question, so feel free to ignore me if it's too much. So there are many challenges, as you mentioned, that are beyond what is the research project on that. That was music for my ears to hear a huge call for reporting which population you are actually including. But that drives to other problems to say, what is the information we have about the demographics of the people who are having this disease? And when you start looking for this information, realize it's also quite poor. So then trying to make your sample representative is also complicated if you don't know how it's composed to start with. But also reflecting on experience, like I used to work with a sarcoma research group, when they had problems with recruiting people for their trials. And someone just said, well, the problem is the trials you're doing. You're making such selective populations that doesn't match my multimorbidity or sarcoma patients that I see every day. And then it's a matter of also what are the questions you're asking. And when you start looking what is your population and you look what are their needs, the questions that are coming for the trial are also different. Do you get into this kind of rethinking the whole inception of the trial?
Yeah, and it's a complicated question and really complicated issues. But you're right, thinking about that kind of roadmap idea, that if you're not including the right kind of voices, when you think about what your research priorities are, you're not including the right kind of voices when you think about what gets funded and what doesn't get funded. It's no good designing an inclusive trial because you've already kind of missed out, not that the point, but you've already missed out a lot of the important factors. So it is very much across that whole kind of ecosystem. And that is where things like funders thinking a lot more around uptake of research priorities, but also who is included in that and the methods used for that. Again, that move towards doing more things online might mean that more people that need greater support, that need time, space, that don't have access to digital technology are excluded from those conversations. So that's why it's not just the intervention component, it is across the whole completely. And that's where this kind of commitment from funders and others actually needs to be demonstrated throughout. Involving clinicians who say, when they say, okay, this is not the population I recruit, that's why trying to engage in them at the earliest opportunity and thinking about criteria. And there certainly is then tension on about the sponsors and the risk appetite for including these groups. And you could look at other populations within pregnancy, breastfeeding, for example, to see what that kind of risk concern looks like then when you exclude any trial, even though they're not likely to receive the information they will benefit. So a lot of that is a kind of attitudinal change that requires everyone having that same kind of agenda. And we can see the kind of commitment to improving inclusion of ethnic minority background, for example, that again, COVID gave a really strong indication that we did a poor job historically of including those groups in trials. But because of the issues, we need to do much more around demonstrating our trustworthiness, for example, with populations that quite rightly don't trust us. It is a deeper kind of philosophical change that we need as well as awareness across society. People don't go around thinking about trials automatically, and that's where it's quite nice to hear initiatives coming around raising awareness about trials. And certainly that advanced research planning, when I've spoken to people have described how, you don't sit down on a Friday night at the pub and start talking about what you would like in research, music about it in the future. Quite rightly, there's not a place for it. But it's about raising awareness about research more broadly, about trials, and increasing opportunities, taking that as well. So really, really complex issues, and we have to start somewhere, and that's where some of these kind of practical tools actually support more meaningful discussions, conversations, attitude change, commitment. But from a behavioural perspective, it's much harder to do, but will have to be part of that kind of big
picture. Great talk. With respect to the impaired capacity to consent, I assume there's a lot to be learned from sort of the ICU and critical care literature, and what's transferable and what's not.
Yeah, exactly. So that's kind of where my kind of clinical background is. So that's the kind of population and setting I'm very familiar with. And that's where the kind of time-sensitive nature of things means that actually you need to act quite quickly. But you're right, there is also learning from that as well. And part of the learning, I think, is about understanding that parts of our healthcare are learning systems, aren't they? So if you are a patient in critical care, care that you receive is based on evidence drawn from previous patients, so you know what the best way to treat whatever critical illness it has. So it's also that idea that actually when we are users of healthcare services, that are we also then contributing to knowledge and how we can draw on it. But there are also some very specific components to that, aren't there? So where a critical care patient is, and you know how to access them because they're right in front of you. And that's harder when we think about, for example, a dementia trial being run in the community, where if you mail out an invitation to take part, and a person is not opening their letters, not able to read their letters, not able to necessarily then take the action to sign up, how that might be conceived as not wishing to take part in research, when actually it's the nature of their condition that's made them unable in that way to kind of engage in it. So you're right, there are ways to learn from different settings and populations, but then also that kind of context-specific difference is important. That's where hopefully things like that framework can help people to think through that a little bit. And resources, for example, from critical care trials, then on that website, so people could then look at another setting, another population that can be reported how a kind of recruitment process has worked or not worked, and hopefully draw lessons from it.
I've seen any other questions online, so I might just ask one that's it's a little bit tangential to the trial context, but you mentioned obviously patient public involvement in the UK. We have the strategy for patient-oriented research here. And one of the issues that we face with patient engagement at PPI is actually diversity and inclusion within the PPI. And I just wondered whether, given your work to engage interest holders in that process, including patients with impaired capacity, I just wondered how that had worked and whether you had any sort of advice or thoughts on that process.
Yeah, again, and that's a really common challenge, isn't it? That where we might have existing relationships with the public that contributed to our work, it's the easy thing, isn't it? To go back to those groups and to keep going back to the same groups and individuals, and that doesn't increase their diversity. So it's definitely a challenge. And a lot of that's the route we try to go down is through community groups that traditionally haven't involved in research, but we do have engagement with growth candidates, and where that kind of finding partners to work with can introduce you to other individuals. But that idea that actually the methods we do that might or might not be inclusive. So again, if we send a mail out to community group and anyone that's interested in taking part can email us back, again, that's naturally exclusive of people that might not be able or willing to choose to communicate in that way. So there's also that kind of outreach as well, going along to where you might find people. So a dementia cafe, for example, where it's set up in a community hall and people come along for a cup of coffee. I've never talked about research, but might be willing to perhaps have a short talk about research. You kind of bring that human face to it and to address people's questions before you even then talk about would you like to then take part in that involvement group. So it's about building relationships. Again, we could get into the time resources available for us as researchers to do that, but again, I think that's part of that kind of bigger conversation around the commitment to that, recognising that it takes additional time and resource, and also that you can build relationships, but they can also disappear quite quickly if we don't go back and report back to them. Keep that kind of communication loop.
Wow. I don't see any questions online and I don't see any hands in the room, so I just want to echo Dean's. I want to say thank you so much. That was an absolutely fascinating and thoroughly interesting talk. So thank you very much.